Impetigo is the topic for today's discussion. Uh, it is a skin infection which we come across quite often these days. That's why I have chosen this topic for today's talk. Impetigo, by definition, is a highly contagious bacterial skin infection which characteristically presents with erythematous lesions. They progress onto formation of pustules and typically affect the superficial surface of the skin. There are two main varieties of impetigo infection. These lesions could be non-bullous, which means there is no blister formation, or they could be bullous, which means there is formation of blisters. Really, the infection goes to the depth of the skin with involvement of dermis, and they give rise to lesions which we call as the ecthyma. Very rarely, there is some pre-existing skin lesion in the form of burns, and there is secondary impetigo infection, and we call it as the impetiginisation of the pre-existing lesions. Here is a child who presented with erythematous skin lesions involving the left auricle, and the parents had also noticed swelling of the retroauricular lymph nodes. The patient had fever and malaise, and this was a characteristic non-bullous impetigo. Here is a girl who presented with formation of small blisters, and they can be appreciated on the second toe. And the patient also complained of similar lesion evolving on the adjacent third toe. So it was a case of bullous impetigo. The patient was adult. It is a child who presented with erythematous non-blistering lesions on the nose and the chin. Once these lesions are treated and the lesions are no more in the active phase, they typically leave behind scaly rims, which we call as the collarati. With further skin treatment, these scaly lesions also disappear and there is complete return of the normal skin. Here is a child who had scale burns on the cheek, and the child developed secondary impetigo infection of the lesions. Hot and humid weather is one predisposing factor. We come across such cases quite often these days. The other vulnerable population would be those who live in crowded environments, such as the nurseries and schools. Compromised skin in conditions such as a pre-existing skin lesion or burns would also predispose to the evolution of impetigo. Immunosuppressed individuals are more at risk. Similarly, those who are living in poor hygienic conditions may also develop such lesions. These are the two leading forms of bacteria which give rise to the skin lesions. They are the Staph aureus and Strep pyogenes. Diagnosis is usually straightforward, and it is based on the clinical findings of the lesions, which have characteristic features. Rarely we may send the fluid from the blisters for culture sensitivity, and they usually come out with the same Staph aureus and Strep pyogenes. Very rarely, biopsy of the lesion may be indicated, and the histological features on biopsy are very typical. The differential diagnosis is in the form of similar lesions on the skin, and they could be pemphigus foliaceus, pemphigus vulgaris, pustular folliculitis, herpes simplex virus, especially of the lips, and other similar infections of the skin. Two main types of impetigo are found. One is the non-bullous, which is more common, and the second is the bullous impetigo. And this bullous formation, or the formation of blisters in bullae, is because of a toxin produced by the Staphylococcus. Non-bullous impetigo is more common, more prevalent, and the lesions may be found in the face, hands, feet, and other parts of the body. Typically, it starts as a single erythematous macule, which then progresses to become pustular vesicle. Once the vesicle rupture and they are deroofed, they ooze out serous fluid, which rise up and leave behind characteristic honey-colored crust. Also, there is usually minimal or no surrounding erythema around the lesions. Satellite lesions are quite common because of autoinfection or autoinoculation. Similarly, kissing lesions are also quite frequent. Usually, the patients are systemically well, and sometimes the patient may have the complaint of itching and enlargement of lymph nodes. Bullous impetigo is rare as compared to the non-bullous form, and these lesions may be found on any part of the body, especially the face and limbs. They may be spreading rapidly because of autoinfection or autoinoculation. Once the blister deroof, it oozes out yellow fluid and leave behind a cholerated lesion. The patient may have the constitutional systematic features of febrile illness with malaise and lymphadenopathy. The medical treatment is directed towards addressing the Staph aureus and Strep pyogenes infection. So we have two choices. Either we use topical antibiotics or we use systemic antibiotics. We may use the two in combination. Topically, mupirocin, fursidine, fursidic acid, and other forms of topical antimicrobial agents are our choices. Systemically, we prefer to use oral antibiotics if the patient can tolerate oral. Injectables are indicated if the patient is not tolerating orally. We have a set of indications for systemic antibiotics, such as the bullous impetigo, lesions which are more than three in number, and topical antimicrobial treatment has failed. Individuals who have comorbidities in the form of diabetes or some immunocompromise. Similarly, patients who have febrile illness, malaise, and lymphadenopathy. Our choices of systemic antibiotics are poamoxiclav, amoxicillin, flucloxacillin, and others. How to prevent the spread of impetigo? First thing, we shouldn't touch the affected areas. This will help to prevent autoinoculation. We should try to avoid contact with the lesions because this is how it spreads to other healthy individuals. We should try to maintain good hygiene. This is how our immune system is boosted and we are protected. We should not share towels or bedding with the infected individual. And if a child becomes infected, we should not send him to nursery or school. This is how the other healthy children are protected. Most of the time, the impetigo lesions respond very quickly to the antibiotics. Really, some patients may continue to have persistent issues, such as hypo or hyperpigmentation of the affected areas of skin. Patients who have ecthyma usually have more scarring. Sometimes, because of the spread of infection, the patient may have cellulitis, lymphangitis, and bacteremia. There are certain rare conditions which may be associated with staphylococcal and streptococcal infections. For example, the staphylococcal scalded skin syndrome, scarlet fever, or streptococcal glomerulonephritis, and streptococcal toxic shock syndrome. These are very rare, and most of the time, the impetigo lesions heal without leaving behind any scarring or pigmentation. The topical antimicrobial agents are available in different forms. For example, we imply a combination of acetic acid with hydrocortisone. If we think that there is involvement of MRSA, we may move on to the employment of mupirocin. Uh, Oral antibiotics are commonly implied in the form of augmentin or calamox. If the patient has some contraindication to the use of coamoxiclav, for example, pregnancy, then we prefer to use amoxicillin and flucloxacillin. Once the patient has no more the active lesions, we then advise the use of aloe vera and vitamin A. These help to ensure quick regeneration of the skin and without any pigmentation or scarring. Thank you very much, and stay in contact if there is an issue. Thank you very much.